Great. The recording is on. Welcome everybody this afternoon. Hope you're not all melting too much. Good to see you all. It's we have apologies from Mel from the LMC, Heinz on holiday, Alex from Health Watch, but Judith is here instead, and Michael Dennis from the medicines team, but he has sent a substitute as well.
Chair, sorry, it's Carl Gosling here. Can I just add that Parveen Mercer is unable to attend and I'll be presenting the papers on her behalf.
Yeah, that's great because I think Parveen having IT issues.
IT issues, yeah.
They must see that it's a primary care committee and they play up with her computer just to cause her a wee bit of grief. Are there any declarations of interest that's not been previously declared? Silence, I take as no.
Sorry, Dominic, can I just a comment on declarations of interest? I think it would be normal practice to have the register of interest here with the committee papers. I was discussing that with Karen this morning, and we'll make sure that that's here visible for future meetings.
That's great, because yes, it's one of these things that's kind of slipped by. But Tracy.
Yeah, I just want to say, because the interest register isn't here, that I have a conflict, I think, and I'm sure it's in this part of the meeting, when we're discussing, we are discussing Bowthorpe here, I believe, aren't we, the Care Village?
Yes.
Yeah, so my practice, Castle Partnership, are subcontracted to provide that service, so just so that's noted. So though I'm not making a decision, but it is a conflict.
Okay, thank you very much, Tracy. Noted. Can we move on to the minutes of the last meeting? I've been notified a couple of errors in the minutes. One was an apology to, now we've got your name the wrong way around, Tom. We've got your name the wrong way around, surname and first name. So that will be amended. And on page 12 of the minutes, there was a proposed amended wording from Health Watch Suffolk, where it says the annual report from primary care was due to lack of engagement. It should actually read, but due to lack of engagement, COVID-19 related, we will not be producing a report this year, just to clarify the reason why that's happening. Are there any other factual inaccuracies or amendments anybody want to raise at this point? No, we're happy to take that as the true record, subject to those amendments. And are there any other matters arising that's not covered elsewhere in the minutes, sorry, in the meeting today? No, that's great. So we'll move on to the action log, which we've got 3 actions to be updated. One, actually, they're all for closing because the legacy action has that was circulated via email. There was a report that was supposed to have gone to an April primary care committee meeting, but obviously they didn't happen. That was sent to the committee members via email between meetings, so that can now be closed. I've signed the last set of minutes, so that can be closed. And adding the local commission service, that's also been added to the forward plan. So I think those can be all closed, unless anybody has violent disagreement with that. No, thank you. And we move on to the risk register. Are you taking that, Mark?
No, Sadie is on.
I'm here.
Oh, hi, Sadie.
Sorry. I just, would it be okay if I could just share my screen, because there seems to have been only the first page of the risk register included as part of the paper pack, so I apologise for that. hopefully you can all see it.
Yep.
So as mentioned in your verbal update last time, Doris, this is an interim version of the risk register, which as a CCG we continue to work on. So it's still a work in progress. We've tried to capture the key strategic risks. However, these may well be added to or further developed as we continue working on this. And I'll just give you a quick summary. You've seen the first couple, which are around the resilience of general practice and the workforce issue. And we have a paper on the workforce, general practice workforce later on the agenda. The other risks that we've included at this stage are around estates and a mismatch between what we need and what we've actually got. And we have a project which was paused as a result of the COVID response, but it is starting up again now. A project to map all of our primary care estates across Norfolk and Waveney. And that is actually starting off in Kings Lynn and piloting the Kings Lynn practices simply because it seemed to be the most sensible approach with two really big developments happening in the centre of Kings Lynn. Moving on, we have a risk around locally commissioned services. Many of you may remember that this was a project that was commenced probably a good year or so ago now. That again, we have not been able to progress because of the pandemic, but we are now working on again, and we will, as per the action log, be bringing a paper to the September committee for you to consider on that. Then we have a risk around the delivery of improved access and extended hours, including the ability to enable the technical issues to be overcome around direct booking from NHS 111. And I think, again, these services were largely paused through the initial phases of the pandemic response, but we are now working with all of the localities on this, and we're making really good progress. Parveen will be able to update us on this in a future meeting. We've identified a risk here around flu, and this will obviously be a risk that comes and goes from the risk register because it is a seasonal issue. And I think particularly this year, we've seen from the news and from the briefings nationally that flu is going to be a really, really big piece of work for the whole system this year, particularly for general practice. And Kath is our system flu lead and is leading a new flu cell which has been established. I think we're at a really good stage in terms of our planning around flu, and the localities are working very closely with PCNs to prepare the PCN and practice plans around this and the actual operational delivery. I think it would be a really good thing to bring our flu plan to the next meeting, and perhaps we'd like to record that for the forward planner for next month. And I think we'll be at a stage then where hopefully we've made some good progress following the flu letter which was published last week. The next one is around learning disabilities. This is something that we've been focusing on for probably a good 12 to 18 months now, and we had quite variable uptake across Norfolk and Waveney. It's something that the Norfolk Health Overview and Scrutiny Committee have taken quite a significant interest in terms of the level of uptake. Our target uptake is 75%, having increased from 50% the year before. But obviously this is an area that was paused in the initial stages of the pandemic response, and it's not an easy thing to deliver remotely via video conference and what have you. And in fact, because of the need for screening, it's not something that can be completed 100% across a remote consultation, even if the target group was open to having services delivered that way. So this is something that we are working on. Again, it's a system-wide response for us in terms of supporting the delivery of these health checks in general practice. And this is something that Parveen needs on behalf of all of the localities. We have a coronavirus risk around our ability to respond, and that links into the impact of staff shielding, risk assessments, PPE, test and trace, and the need to socially distance. And then we have a couple of medicines risks around cost pressures and high prescribing rates that predate the COVID pandemic in terms of hypnotics and anxiolytics, and high prescribing of gabapentins in primary care, where we are an outlier nationally, 14th place as a CCG. And this is, again, all of these prescribing risks. We previously measured these on the 5 individual CCGs, so it was easier to see where we were outliers. Now, for example, with opioids, we are being measured as one CCG, which masks some of the individual issues. The prescribing team, which Kath leads, are very well aware of these issues and are looking at how we can work with and support practices to address some of these areas. And we're in continuing discussion around the implementation of a prescribing quality scheme, which again will address and cover some of these issues with practices. So we'll send this risk register out again. Apologies for, I think it's probably an issue with converting the document into a PDF document to go out with the papers. So I'm sorry about that you haven't got it before. Very happy to answer any questions now, but equally, once people have had a chance to digest the contents a little bit more, to come back outside of the meeting, and we'll obviously be reporting this monthly now to the committee going forward.
Thanks, Sadie. That's very helpful. If you can send it out, then we can have a chance to have a look at it. Are there any questions for Sadie? Tracy?
Sorry, Doris, you were breaking up there. Yeah, I just think sort of emphasising to me when Sadie highlighted in respect of some of the prescribing and also the LD health checks and other areas on the risk register, that there will be huge variance across the localities, across practices. So kind of for us to really focus on that variation and working on that. And I think we can't underestimate that a lot of that work will have to take place within the localities, and working with our localities, associate directors and our PCNs in order to improve those outcomes in those areas. So it's just something that really was highlighted to me, just reading through those risks, that the answers and the work will take place in primary care within the localities.
Yeah, thank you. John?
Thanks, Doris. A couple of quick comments, if I may. I don't think, Sadie, I saw a financial risk related to primary care within the risk register. Apologies if I missed it, but I do think there's something. I know we're seeing quite significant pressure on delegated budgets this year in particular. Yeah. I think it would be good to flag that on the primary care risk register, and maybe we can just pick up offline on wording.
Thanks, John.
Also, I'd just like to pick up on the prescribing issue as well that Tracy's highlighted, and I know it's mentioned in the prescribing report later. I think we're third highest in the country on hypnotics and anxiolytics. I just wonder if it would be helpful if the committee received a paper about what we're planning to do about that and how we need to engage practices going forwards to try and address that, because recognise all the pressures on practice related to COVID, but high spend in these areas is a financial issue, but it's also very much a patient care issue as well, isn't it? So it feels right that we do have a focus on that. Sorry, Kath, it's not something we discussed before, and I don't know if that's something you would support.
Yeah, I would support it. We talked about it, Kathy, and I and Peter talked about it the other day in relation to the Quality Committee, but felt it really is about PCCC, but recognising that we still are an outlier in this area, and there's still, even though a lot has been done, and there is still a lot to be done in this area. So it would be quite helpful, actually, I think, if we brought a paper on dependence forming medications and where we are and what needs to be done.
I think as we are dovetailing the work between Quality and the Primary Care Committee, that would be great, because I don't want to create work for but I'm sure you have that under control.
Yeah, I think it should come here, Doris, to this committee, because most of the prescribing is done in primary care.
Yeah, that's fine. Thank you.
Or the consequence of the prescribing is also felt in primary care as well.
That's great. Kathy?
Yeah, sorry, just to confirm what Kath was saying, I think we agreed that even though we briefly discussed it in Quality, and I think that was mainly because Peter was there and he's got a very deep interest in this matter, that it was certainly something that would be discussed at Primary Care Commissioning Committee. And where we landed in relation to Quality generally, just to clarify for everybody, is that if it's primary care, then it comes here. If it's primary care, but also, well, it's system, but has some primary care involvement, obviously we may discuss it with the Quality Committee. So just to be clear about bringing it here.
That's great. Thank you. Are there any other questions? Mark, sorry.
Sorry, I didn't know where to state the obvious, but I know we're talking about restoration later in the agenda, but actually this is I think a good example of the stretches on the resources in the teams, and actually we're making sure that we do prioritise correctly, and that's why the risk register is so helpful. Because actually there is some very important work that we do need to do around restoration of services. And make sure that we prioritise the resource of the CCG as well in supporting primary care. So just to state the obvious, but I think it's an important point.
Thank you, Mark. I think that's no other questions from anybody. Thanks, Sadie, for sharing your screen, and it was good to see the full register. I did think it looked a wee bit light with just
yeah, apologies for that.
Thinking. So no other questions. We'll move on to the finance report, which is a verbal update.
Thank you, Chair. So there isn't a written report this month because of the timing of the committee. We're still actually going through the process of finalising the numbers for the month 4 position. But there will be a written report that will then come to the next meeting of this committee, looking back at month 4. Just to reflect on what the committee received last month, which was the position for 3 months into the year, that reflected a gap of around £5 million in the area of primary care in general, in terms of our year-to-date financial position. And that was partly delegated primary care, but also prescribing and other broader primary care pressures. At the time, we were talking to NHS England about retrospective top-up funding and supporters to cover that gap. And I'm pleased to say that since then we have received that funding. So we've covered off the gap that we had for months 1, 2 and 3. We've got a similar process and a similar issue going forward with month 4, where we're having a similar gap on primary care, and we'll be applying to NHS England an improvement again for further top-up funding for that. So that's probably all there is to say for this meeting. But as I say, there'll be a full written update as normal to the next meeting.
That's great. Thank you, John. Any questions? Yeah, Tracy.
Yeah, hi, John. Can I just ask, so is that gap going to continue all through to keep repeating that process, or will it work itself out? Because clearly there's a mismatch.
Yeah, you're quite right, Tracy. So the answer is yes and no. Straightforward, is it? So what we've been saying to NHS England regional team is that the way they calculated the funding for this year had some fundamental flaws in it, because of the interim arrangements, because of the pandemic, they put to one side the allocations that we should have had for the year, came up with a different methodology for the whole country, which looked at what people spent last year, tweaked it a bit, and then gave us some money for this year. So within that, our allocated allocation was significantly less than we would have had if we'd gone back to business as usual levels. So that's been the basis of our NHSEI about that gap in the allocation they've given to us. So because that comes through the budgets on a monthly basis, yes, it will still be there going forwards each month, and we will apply for top up. What's changing though is that nationally they're coming up with a new financial framework for the last 6 months of the year, which looks to learn from these first few months, give revised allocations to organisations, to CCGs, to reflect that. So I would hope and expect that those top-ups that we're having at the moment get baked into our funding for the second half of the year. But that's very live discussions at the moment with NHSEI, and hopefully by the end of August we'll find out what those sums are.
Okay, thank you.
Any other questions for John? No, that's great. Thank you, John. We look forward to the next meeting. We move on to item 7, St Stephen's Gate, the proposal for the premises. I think Jade is joining us. Hi, Jade.
Hi, thank you. So I'll take it as the paper has been read, but I'll highlight a couple of key points for the committee to consider. So it is seeking approval for Stephen's Gate Medical Partnership to purchase their branch site. Some sort of key background for you. St Stephen's Medical Partnership is one of our largest practices within Norwich PCM. They've got a registered patient list of over 18,000 patients. They merged formally in 2019, St Stephen's Medical Practice, with Newmarket Road in 2019. The current position of the premises is St Stephen's Medical Gate is a leasehold property, where the Newmarket Road is a freehold property. The Evaluation Office Agency has carried out a review. So in relation to the actual purchase, there's no role for them to play as a sale of Newmarket Road, but we have obviously carried out a review of the lease premises of St Stephen's Medical Gate. The overall risk for the CCG is based on the consideration of the estates team. It's a low risk for the CCG, and this would obviously, the purchase of this would be benefits to the wider STP estate strategy. From a decision, if it wasn't granted today, I guess the areas we'd like to highlight is this will potentially pose a wider risk for our central neighbourhood. The branched surgeries used as part of our COVID-19 response, particularly for seeing our high risk category cohorts within partnership with St Stephen's Medical Practice. And also they host a lot of additional workforce roles on behalf of the Norwich PCN as a whole. I'm happy to take any questions if the panel has any.
Any questions from anybody? No. I think the paper is very clear. Thank you very much. Are we happy to approve the proposal? If not, from yes. That was an easy approval. Thank you very much, Jade. Thank you.
Thank you.
We move on to the Bowthorpe Care Village paper. Do you want to just come off, or well?
That's Carl here. I'll present that paper.
No, sorry. I think Tracy's got a conflict of interest. That was the.
Okay.
Sorry, I'm not a decision maker in the committee. I can come off if you want me to. That's fine. Do you want me to?
I think for clarity, we probably should. If you,
Okay, I'll go out and then you need to let me back in again. Okay.
I'll get Sarah to message you to come back.
Okay. Okay. Bye.
Thanks. Sorry, Carl.
Hello, can everyone hear me?
Yep.
Yeah. Yes, presenting a paper today for the onward contractual element of both Care Village by the Norwich locality. As I said, Norwich locality has in place a separate contract arrangement for the provision of primary care and enhanced primary care to 3 care homes for a number of years. Formally, this agreement ended on the 31st of March 2020. The contract goes back to 2015 when the Norwich CCG were made aware of the care village being built and has been contracted up until, say, 2020, where it formally ended. The care homes include Bowthorpe Care Village, which is an 80-bed residential, well as St John's, which is a 60-bed residential unit, and Oakwood House. Funding for the contract has been set at 194,000, and what we're looking at today is exemption agreement of the committee for the exemption to contract standing order until the 31st of March 2021, approval to proceed with a tender waiver until the 31st of March 2021 for this procurement, and approval for Norwich Practices Limited to be contracted to deliver Bowthorpe Care Village until the 31st of March 2021. I'll take any questions.
Thanks, Carl. Are there any questions for Carl? John?
Just a couple of points, Doris. One technicality on the paper. I don't believe it's for this committee to grant the waiver of the procurement. I've already actually done that because that's delegated to myself or Melanie to be able to do that. But I suppose the more substantive point is I do have a concern. I don't see any option other than to continue this to 31st of March, but this is a contract that has been extended now a couple of times. It's an expensive contract, I think, in comparison to other care home support, although I do recognise that the nature of the patients and the care they need is potentially at a higher level. But just we do have a substantive approach from next April to the provision of care for these facilities, and also something that we can recognise as being value for money and comparative to what we're supporting in other care homes as well. So whilst I'm kind of supportive for now, it's a plea to make sure that we can actually get that redesigned and make sure we have something sustainable from next April.
Kathy?
My comment was very similar to John's, really. I was a little bit concerned about the lack of clarity going forward, and it almost felt as if we were kind of limping along a little bit, extending. And what worried me is these are quite vulnerable and quite complex clients. And my question was, bearing in mind at previous meetings we've talked about care home provision and that kind of thing, would we be kind of seeking to have a more kind of common offer and common pricing strategy going forward?
Yeah, I had a similar concern. It's about future-proofing the provision, and it's always feel a bit, this is a bit knee-jerk that we've got to do it because, we have no alternative, and actually a long-term plan so that we're not in the same position come 1st of April. I think that's kind of key for me for this. Hi, Mark. Yeah.
Hi, I thought Sadie might come in, but I thought I'll jump in first. So I absolutely accept those points. And just I think we're in a transition period at the moment. So I know this, we've come here before and discussed about the locally commissioned service for care homes and the work that's going on around that. We're in the process of just finalising the allocation of care homes to practices at the moment. I think all bar 3 across Norfolk and Waveney, we've almost concluded that exercise. So absolutely, I think what's being raised are very apt concerns, but just to assure everybody that I think we are on a journey, and I think part of this extension is to bring everything online across Norfolk and Waveney with that into 2021. So all of those are absolutely acknowledged, and just to kind of emphasise really that that's our proposed approach here.
Thanks for that clarification. Are we happy to approve the recommendation subject to a long-term arrangement being put in place for the end of the financial year? I've got nods from Kathy and John and myself. That's great. Thank you very much, Carl. That's
Thank you.
Thank you. Sarah, could you get Tracy back on? So I'm just going to wait for Trace for a couple of minutes. I think we'll carry on, and I'll ask Tracy if she's got any points when she joins us, because Tracy's on her way. Brilliant. Thanks, Sarah. On to the prescribing report. Who's taking that one?
I've just messaged Lois Taylor if she's
See you, Tracy.
on the agenda, Doris.
Oh, right, okay.
I don't know if you want to jump to the next agenda item.
Yeah, we can do that.
Because I think we're running a little bit ahead of time, so.
Sorry, I'll slow down. So we'll move on to number 10, and then we'll come back to 9, if that's okay with everybody. So that's the staff risk assessment and general practice report for us to note. Are you taking that one, Sadie, or is...
I think because we're just running a little bit ahead, why don't I take that paper? I'm going to assume that everybody's had a chance to read it. This is something where NHS England wrote to all practices at the end of June, and was followed up by some further supportive letters from our regional NHS England team throughout early July. It's obviously been a really big task for general practice to risk assess fully all of their staff, and then put in place the mitigating actions that are needed in order to support staff to work safely during the pandemic. It's been very heavily monitored by NHS England, and we've included the questions that we've had to report on every week in the paper. In terms of the CCG and its support for practices, there is already an element of occupational health support in place for general practice, some of which is funded by NHS England and some of which is funded by the practices themselves. But obviously, we found ourselves in quite an unusual position with the COVID pandemic response. So what we have done as a CCG is we've worked very closely with the Norfolk and Norwich Occupational Health Department, with the local medical committee and with the localities to commission a web-based tool, which we've put in place initially for 6 months, which provides a really consistent approach through various algorithms to undertaking a risk assessment of staff. We hope that it will be in place on Friday, this coming Friday, with if everything continues to go to plan. And that will allow practices to keep their risk assessments really current, really fresh, and to use it for new staff as well as their existing staff. We've also run a number of sessions on training on practical local risk mitigation. My colleague Kate attended one of those yesterday, being provided by the Occupational Health team at the Norfolk and Norwich, and seems to be really well structured and really supportive for practices. And we're obviously recording that, and we'll make it available to practices. We're repeating that 5 times on various different dates, last week and this week. And then as a result of that, for the very small number of staff that will need onward referral for occupational health support, then that will continue in line with existing arrangements that are already in place. And the Norfolk and Norwich has confirmed it does have the capacity to manage those onward referrals, because they do expect the numbers to be small. So I think, you know, from what I understand, albeit it's not in place yet, the offer that we've been working on for practices has been reasonably well received. I think the local medical committee has been supportive of it, and we'll keep you updated when the contract actually starts from Monday. I don't know if there are any questions on that.
Thanks, Sadie. Tracy?
Yeah, I have a question. So it's really positive to hear about the support with the risk assessments, the tool, and obviously the occupational health element that's coming from the NNN for the Central Belt. And I assume, is that for a question in respect of kind of East and West, what if the occupational health support is in all parts of the county for all localities? So that's one question. The other question is, and then, so it's the what, and the plans when we have the risk assessments, we have individuals perhaps because of, you know, health reasons, be they from a high risk group, perhaps need to work in different ways, and it's supporting primary care in respect of kind of workforce resilience, you know, when people might need to work in different ways that might affect some of our practices more than others. So kind of a question in respect of the and what after the risk assessments and the occupational health and the resilience in primary care when staff kind of roles and what they can do and able to do because of that are affected.
Yeah, I think both of those are really good questions. So the NNN provides the occupational health service to all Norfolk and Waveney practices, albeit that we understand that some practices, I think particularly in the Waveney area, have chosen to access occupational health services from another occupational health department in Ipswich Hospital, and they can continue to do that. That is not affected by the online tool. But the offer is there from the NNUH as well. In terms of the impact of the risk assessments, I think that's a really valid question, and so the training I think is really helpful in terms of being very practical, common sense, and supporting practices in undertaking those local risk mitigation actions to support their staff to work in the way that they are safest to do so. A byproduct of the package of this web tool is that we will get a report as a CCG, anonymised, so that we will understand where the greatest impact is from this. So if there are a high number of high risk, then we will be able to see where those people are and will be able to offer support. We've also done quite a bit of work in trying to support PCNs around business continuity planning and encouraging a PCN approach to the provision of services. And I think once we've been through this web-based risk assessment process and we've got more robust, more consistent approach to the risk assessments, then we'll have a better picture of where our hotspots may or may not be across the 5 localities, and then we can determine what support we can put in place or is needed to support the practices. I think that we can do on a planned basis. We're still going to have to respond to unplanned issues, such as through test and trace and outbreaks and things like that as we go through. But this should give us a much firmer footing for supporting the resilience of practices going forward.
Thank you. That's really comprehensive. Thank you, Sadie.
Yeah, it'll be interesting to see, you know, once the thing is rolled out, actually, you know, how effective it is and actually in use, and no doubt there'll be a report coming back.
Yes,
in a month's time once things are bedded down. Are there any other questions for Sadie on this one? Mark?
A comment rather than a question. Just to check, Sadie, I think I'm right in saying, aren't I, that actually the tool, what is particularly good about the tool is it's as the national guidance changes, you know, mindful that this is a fluid time that we're going through and things change quite rapidly at the moment. The tool is updated and therefore, you know, things change. And so, you know, that is another benefit of this tool, actually. So we won't, you know, it's a live exercise rather than just a do once and it's done forever. Actually, we're encouraging staff to continually check and just making sure that we're supporting individuals. I think that's right, isn't it, Sadie?
Yeah, yes, that's right. The algorithms can be updated quite regularly. So obviously now shielding staff are able to start to return to work where it's safe for them to do so, and that is all being reflected in the algorithms and the way that the web tool works.
So is the updating done sort of externally, so we don't have to keep on top?
Yes.
Yeah.
Yeah, although the company have been really responsive in working with us, they've worked very closely with CAFICO, which is the information governance organisation for the practices, to make sure all the information governance is right. And they've been working very closely with the occupational health team at the Norfolk and Norwich to make sure the front end looks right for general practice. So it is different to that which has been provided for other providers, such as the hospitals, to make sure that the way it works suits practices. It's not a one size fits all. So they have been really responsive in working with us to get this right.
It's great. Thank you, Sadie. John?
Thank you, Doris. And sorry, Sadie, it might be you've covered this earlier, but it's pleasing to note in the report that 104 out of 105 practices have offered the self-assessments to their staff. But do we know what the rate of completion is, or is that something that we'll only know once the tool is live and we're getting the reporting?
No, we're still working with practices on this, and I think there's a difference between practices doing the right thing, which I'm fairly confident that they're all doing, and then telling us about it and providing the detailed responses to all the questions on the return that we have to provide to NHS England. So that's the bit that we're now working on. It's making sure that the numbers are reported correctly. We've had quite a few data errors in some of the returns. So at the last count, I think we had 35 of our practices where we're fairly sure, actually, knowing the practices, that they will have done all of this, but the data just doesn't reflect what they're doing. So that's been the focus now. Mark's been overseeing that through the primary care cell, working with the localities. And we will continue submitting weekly returns to NHS England until we've reached 100%.
Thank you.
Any other questions for Sadie? No, thank you very much, Sadie. That's very helpful, and hopefully that will also reduce the workload at primary care level so they don't have to send us more information for reporting. Can we go back to item 9 on the prescribing, because Lois is with us? Pass it to you just to introduce, assuming the report's been read. Thanks, Lois.
Thank you, Chair. So I will just go over some headlines for this report. Firstly, just a point about engagement. Obviously, because of COVID, we stopped our regular engagement with GPs, but we're now going to start our prescribing these meetings from September onwards, and they will be chaired by Andy Douglas, our GP clinical advisor, which is a really positive step forward because we've not had a GP available to chair those meetings before, and I think it will really help with some peer-to-peer challenge and promote some good discussion. So positive point there. Moving on to prescribing performance, not so positive. You will see from the table that we've had a significant increase in spend in March and to a lesser degree in April. This was as a result of some stockpiling behaviour that went on in relation to COVID. And in particular, we had a huge increase in respiratory medicines being requested, inhalers. Also, we had a big switch from warfarin over to newer anticoagulants as a result of national guidance and obviously the difficulties in testing people's INRs at that time. So significant cost pressures remain. We had a lot of these last year, but we still have supply issues with very commonly prescribed drugs. So you can see in the table, 2.5, a year-to-date cost pressure of 1.9 million. And that will continue this year to be a problem for us. Moving on to quality, so dependence-forming medicines continue to be an area of concern for us. Pleased to report that we have seen quite a lot of progress in the prescribing of high-dose opiates. So our position nationally is much better than it has been. However, we still have a lot of work to do around that to continue the pace of change. Hypnotics and anxiolytics, you will see, is still a real problem for us and needs some real focus to improve this. Both high-dose opiates and hypnotics will be included in our prescribing quality scheme, which will hopefully come to this committee next month for approval. Practices will be asked to put together action plans on how they plan to tackle and reduce the prescribing of those drugs. Antibiotic prescribing, I just want to highlight the variance in broad spectrum antibiotic prescribing. So overall, as a CCG, we are below the national target, but we still have pockets of poor performance, specifically in the West and North. And then there are just a couple of areas, on the antibiotics, we will also be including that in the prescribing quality scheme. So practices will be asked to audit their use of broad spectrum antibiotics. And then a couple of other areas where we have noticed we're outliers. Non-preferred NSAIDs, so these are pain-relieving medications that put patients at slightly increased cardiovascular risk. We would prefer naproxen and ibuprofen to be used, but we are outliers there. We are also outliers in our poor use of high-intensity statins, which is worrying because we're clearly not doing the best in terms of reducing cardiovascular risk for patients. Not clear on the drivers for this, whether it's a lack of clinical awareness as to NICE guidance or whether it's patients not wanting to take high-dose statins, but we're going to do some work on that around our prescribing these meetings and starting some conversations. So those are my headlines. Any questions?
Thank you very much. Are there any questions, Tracy?
Yeah, Lewis, can I just ask, in respect of the stockpiling aspect that we had, obviously during the pandemic, are we expecting that some of that might lessen and might correct costs a wee bit if people are using that stockpile, or are we worried that they're still going to keep ordering more repeats? Because we could do a campaign about if you've got medicines and use them up kind of thing, just a thought that occurred to me. Something else that occurred to me in respect of the antibiotic prescribing, I think we'll see more prescribed because certainly I'm doing lots of stuff by video consultation. I think we're prescribing more antibiotics because we're not stealing people and we just want to prescribe to take care, be careful in case there is an infection. I think there might be a lot of that happening as well, which is a bit of a concern, I guess.
Yeah, absolutely.
Because of that.
Yeah, absolutely. I think definitely antibiotic use will have increased because of COVID. And I think we've seen an increase in C. diff cases. So we need to look into that and hopefully behaviours will start to normalise again. And just going back to your point on stockpiling, just using the pod service, we saw this huge increase in ordering and then followed by a big decrease in ordering. So I'm hoping figures will start to level out a bit. Yes.
And just another thing, because the incentive scheme is going to start later than it normally would as well, isn't it? So I guess we've got to factor in that savings that we might expect, you know, we've got less time to get them kind of thing. But I think important for the quality aspects of that, and certainly with the NSAIDs, I mean, it's horrifying that the dangers that the wrong ones can do. So I think is that part of the incentive scheme?
It is, yeah. NSAIDs are, and in particular renal function with NSAIDs, which we know we're not doing well.
Okay, good.
Yeah.
John?
Thanks, Chair. Just one comment and one question. So the comment is that on an earlier agenda item on the risk register, we talked about hypnotics and anxiolytics, which you've highlighted, and suggested that maybe a focus on that at the next meeting would be helpful from both a cost and quality point of view. And from my point of view, what are the key things that we can do about it to try and moving down that table, I suppose. And I guess that will tie in with the prescribing quality scheme discussion next month.
Yeah.
And my question was going to be, you referred to a shift from warfarin to oral anticoagulant. Is that a non-reversible shift, or is that something that was pragmatic for that time being, but then patients move back again?
I don't think we'll see a shift back. I think it's very hard to be moving a patient from warfarin to a newer agent that doesn't need the INR testing and then convince them to move back again. Yeah, I think it's done. That is a cost pressure that we'll have to live with. So
I guess it's, and I know that direction of travel has been clearly increasing over recent years, but it feels like this is a step in that increase. So it'd be helpful for me if we could quantify that, and then we can maybe make that case specifically up the line if it's significant.
Yeah, absolutely. Just going back to the hypnotics issue, it is worth pointing out that there is a requirement in the PCN DES for the PCNs to work on dependence forming medicines with CCG. So that's a helpful lever for us. So.
Any other questions for Lois? I mean, there was a comment sort of earlier on, because obviously the 5 coming together, so as a CCG level, it masks some of the good and the not so good. I assume, you know, locally you are able to access data that is much more granular, that can identify the outliers, so we can, you know, you and your team can help move people in the right direction.
Yes, yeah, we are. So when we pull our EPAC data off, we're able to do it to the old locality geographical boundaries and then down to PCN level. So yeah.
And that is presumably shared with the locality team for them to have conversations with colleagues.
Yeah, I think that's some work that we need to do in terms of working out how we best interact with the primary care team and the quality teams to work together to work with practices that are outliers in particular areas, how we triangulate an approach. And also in particular, because COVID has obviously caused a certain level of engagement at practice level with particular issues, it's for us to determine when we start those conversations again and you know, specific engagement meetings with practices. So that some conversations I think need to happen outside to agree on the right approach to tackle outline practices.
Thanks, Lois. Any other questions? No, that's great. Thank you very much for the paper and answering the questions. Thank you.
Thank you.
Right, we're going back on track onto the agenda, the locality report. So I'm just flicking forward to my papers. I see Kate's joined us, and so I think this is a double act between you and Ben, because there's an overview, and then Ben's going to talk to us about Yarmouth Spotlight. Over to you, Kate.
Right. Thank you, Doris. Hi, everyone. So the purpose of the paper is to provide an overview and regular update on strategic plans for our primary care networks. And in this month's paper, which is only the second of this paper to this committee, I also wanted to give you a bit of background background to the sort of transformational structures that are supporting the primary care networks. And I just wanted to provide a bit of a refresh on that, really. So we have the formal governance route for primary care networks, which is through this committee, but also supporting the transformational agenda for PCNs is the STP Primary and Community Care Workstream. And just prior to COVID, the Primary and Community Care Workstream, I think sort of had what I was describing to Doris previously, sort of had a moment, a bit like a teenager, trying to figure out what it's about, and decided that a refresh and a rethink was needed in the context of the ICS. Those plans have been put on pause because of COVID, but given restoration plans and plans for phase 3 and reinstating routine care, these plans are starting to be reignited. And so the primary and community care workstream is looking at honing in its priorities, and top of that agenda is supporting primary care network development. I also wanted to talk about, in the paper, just the finances related to primary care network development. Last year was the foundation year for PCNs, and 845k was awarded to Norfolk and Waveney PCNs to support the development agenda. Only a small proportion of that money was invoiced against, and so we've got a significant sum carried over to this financial year. PCNs are in progress reviewing their plans and looking at how to allocate that funding and refresh those plans in light of COVID. I won't go into much more detail because I'll take the paper as read. Really wanted to hand over the spotlight to Ben, who'll be able to talk about in much better detail than I would plans that are happening in Great Yarmouth and Waveney.
Thanks, Katie.
Thanks, Kate. Am I okay to continue, Chair?
Yep, carry on.
Thank you very much. So I have got a presentation to share, if that's okay, because I did obviously the paper there, but sometimes it's a bit difficult to get everything across. So if you wouldn't mind, I was just going to share. Is that okay, Chair?
Yeah, that's fine.
Okay. Can everyone see that?
Yep.
Brilliant. Thank you very much. So as Kate said, just a quick overview. Well, don't worry, I'm not going to take up loads of your time. Just a quick overview of what is happening in Great Yarmouth and Waveney, just to give a flavour of a little bit of impact of what COVID has been doing to PCNs, but also how we're kind of coming out the other end of it, if you like. So just a bit about our network. So we've got 4 in total. We've got Galston, which is only 2 practices, which is quite unique, but large practices. Clinical director is Andy McCall. We've got Great Yarmouth and Northern Villages with 4 practices, relatively big population. Aoife Slattery is the CD there, and Lowestoft, our biggest PCN of 82,000 with 7 practices, and the clinical director is Lucy. South Wales, we've just had a resignation from the clinical director, but thankfully we've successfully recruited a new clinical director, a lady called Dr. Julia McLean, who's at Beccles Surgery, so that's good. And that happened in a matter of 2 weeks. So I'm really pleased that there was appetite to do it. So which is sometimes quite challenging, especially in this environment. So that kind of gives us a little overview of the makeup of our networks. So one of the things that we're quite unique in Great Yarmouth and Waveney because we have our own community provider. So I see PCNs as much wider than just the DES, if you like. So there's lots of pieces to the puzzle to make sure practices, one, are resilient, but also being able to deliver holistic care. So we work very closely with East Coast Community Healthcare, which is our community provider, and they are aligned to each PCN, where we have primary care home teams, which is led by clinicians from EC, who are the point of contact for general practice, and they have on a day-to-day basis daily huddles with the practice to ensure that they can have coordinated and resourceful care, so we don't have this scenario where like there's 3 or 4 people going up patients pass, so there's one conversation, and absolutely the integration is really going well with that. And COVID has presented some of its challenges, but actually it's been quite good. Even in a virtual world, they are still able to do this quite well. However, now that people are now starting to meet more succinctly in their surgeries. So this will just give you a little flavour of some of the things and some of the what we're doing in Yarmouth and Waveney around the partnership workings. The things we are quite proud of in Yarmouth and Waveney, we have a single joint PCN plan. It's quite a mouthful, where we have a work plan for our primary care networks with the general practice, but also EC feed into that as well. So we have an overarching plan, which you'll see a snippet in the paper, that details out some of the things that we are jointly doing as primary care networks to deliver things like the PCN DES around care homes, but also the flu agenda, but also aging well. So really joined up, where actually we look at a lot of our CCG project management team, but also the EC teams as a kind of almost like an engine room for resource to be able to just direct and deliver projects as and when we need them. So I think that is a real strength of ours, and has really helped in kind of the COVID world, if you like, with setting up like hot hubs and things like that. So we've had to have a real think over the COVID period about how we actually organise ourselves, because all of a sudden March we had quite a good structure, but then all of a sudden we found ourselves having to go into this virtual world, which all of us have. So we've had to really think about our forums where we have wider discussion with our clinical colleagues, but also wider colleagues in ECA and also Paget. So we've got a PCN strategy group, which is mainly made up of our clinical directors, that mainly focuses on the PCN agenda, but then we bring in EC as well to look at the care home piece. So that's really good. And also our GP provider is in there, which also helps give that kind of leadership within across the practices. I've mentioned the single work plan, and it's got the maturity matrix, the 10 high impact actions. So it's quite comprehensive. And if I'm honest, it's more for our benefit so that we can keep track of things, or how things are progressing. We do a kind of mini sit rep for the PCN CD, so they don't have to read the rafts and rafts of details. But all the networks meet really regularly, so they at least meet once a month, and we attend all of those meetings. And some of them at the minute are meeting bi-weekly to make sure they are, 1, prepared for flu, and also 2, prepared for the PCN DES, which comes in October. So yeah, and we also have a wider clinical group as well, which is Paget, EC, and the CDs, where we have a more informal conversation. And this week we've launched 5 webinars over the next 2 weeks, which brings EC operational team and the practices, so the practice can dial into that webinar, and they are now going through a series of kind of workshops and plans to how they stand up their services. Because practices, as you can imagine, there's a bit of confusion out there about what's happening. Is it virtual? Is it face-to-face? What services are standing up? So we've decided to hold these webinars where practices can ask questions via the chat function or verbally. And it was really well attended today and yesterday, and lots of good questions. So it was really, really useful to do that. This just talks a bit about how it's all blended together really, and how the PCN prospectus plans, that's really about us, how we target resource and accelerating the PCN plans, which in the paper you'll see there's kind of 3 or 4 things that we're trying to do. A lot around System 1 integration. That's a big push for us. We are quite lucky that our community provider and all but one of our practices is on System 1. We always have one, don't we? But we have managed to solve some of that through GP Connect. So the EMIS practice is able to book into improved access slots and physio slots and things like that through GP Connect. And that's recently just launched. So fingers crossed and touch wood, that's all going well. And then we've got the place level plans. So that's really about the shared priorities. There's no point in us having a PCN priority if that doesn't really fit with what others in our system want. So really, really important, but also linked to the STP ambitions and the NHS long-term plan, really important. Then we've got some of the primary care network PCN DES delivery, which is around the care homes, which we are quite in a fortunate position because we did have a care home LCS. So we are now trying to tweak some of that delivery to meet the needs of the DES. And we've got a wider group that looks at that, and we also feed into the central group that Parveen is on. And then partnership working arrangements in place to support delivery. So that just gives a flavour of how it kind of all fits in together. This is just a little bit about how we've kind of been working with the clinical directors about how we've been developing them. So they've all been on the time for care vision to delivery. And our South Waveney network has now asked for NHS England to come in again to deliver some of that time for care piece because they would like to look about how they kind of make themselves resilient for the future, which I think is quite good and you know, shows that they've got some decent maturity to look at where decent maturity, you know, to think ahead. Talked a little bit about the recruitment in the paper as well. So we've got recruitment of 15 full-time network posts, which is good. We have struggled with pharmacists in some of our areas, but we are looking at plans with joint posts and things like that. So yeah, it is what it is. Recruitment in GYW is very challenging, like elsewhere. But I would say, coming from my previous post in Norwich, there is definitely more of a challenge in GYW, and that might be to do with the C. Local development implementation of clinical population segmentation tool. I don't know if you saw in the paper, we are rolling out a traffic light system through System 1 that basically it segments patients, but also helps day-to-day resource of where that individual needs to be seen, treated by. So whether it's a GP, whether it's a nurse, or whether a social prescriber and things like that. And that is really helping with some of the capacity within general practice at the minute, especially with footfall. So footfall has really given a new dimension to how you access primary care. And I believe if we didn't have this segmentation tool in, I think our practices would have been flooded. So I think this has really, really helped. You know, developing local partnerships and working together is massively key to, I think, some of the success we've had across our patch. One of the things I do really like is the GP Team Net, which is like an intranet for all of our PCNs. So all our policies, plans, and everything like that are on there, so all practices can access it from you know, receptionists all the way up to GP, and they can see exactly what's going on, complete transparency, and you know, really, it also has a chat function so that they can bring anything to our attention as well. So these are, I'm conscious of time. So these are some of the things that are important to our networks. It's just some examples. So in Gorleston, we've got the Shrubland site, which is a purpose-built surgery, but in Gorleston for what their plans are for the future with EC and the wider community, and we're currently on developing the business case for that. Great Yarmouth and Northern Villages is very much about the operability, System 1 operability across the patch with EC, and about how they make you know, referrals easier, so there's no paper whatsoever. It's purely done through System 1 tasking. And Lucy at Lowestoft, I must say they have really risen to the challenge in this COVID period of setting up one of the most seamless hot hubs I've seen across the patch. Really integrated with all practices. So 7 practices almost sending all their COVID patients into one surgery, which to me is PCN working at its finest and really getting through the bureaucracy, red tape you would normally see of practices going, no, I don't want to work together, and delivering phlebotomy in very different way as well in a hot hub. So really really good, and working with some of the voluntary sectors as well. So, and South Waveney, they've been working on a number of projects across their piece, but really having a particular focus on frail and elderly, and recruiting additional roles. And Kate, the current CD, has been absolutely fundamental. Some national work around some of the paramedics as well. So that's really good. As I've said, within the network response to COVID, all of them had zoning and hot hubs in place, and really, you know, I just couldn't believe the barriers that were just really played their own part. So I'm really pleased with that. And also, we developed a number of protocols for the system across the patch as well. So we developed protocols to cover triage, COVID assessment, disposition and zoning, and shared that with our colleagues, because we were waiting for some national pieces, but unfortunately never came. So really good innovation allowed us to push forward. Just some more around that piece, and I'll stop there, I think, and see if there's any questions, because I'm really conscious I rambled on there a lot.
Thanks, Ben. That's helpful. Any questions?
Sorry, I got a lot of interference. Is somebody muted?
Can just mute yourself, thanks.
Yeah, so I've got a couple of questions. One, probably Ben and more Kate. So I was interested in, Kate, when you said about the primary care, knowing about the primary care STP committee kind of had a rethink and threw its toys out and said, what we're going to do. And to me, that's about the LCS and, the ICS and how we work as a system. I'm interested in the approach and from Waveney with the primary care network strategy group. So is that working in the way the local delivery group might have worked before, and just how would that fit with the with the ICS and in the localities going forward? So bringing all those kind of stakeholders and partners together in the locality. And the other thing, Ben, I was really interested in is the traffic light system for managing the workload in primary care, particularly with footfall, because all practices, I think, without anything system in place, are drowning in footfall, because we've got the restoration coming back with patients visiting our surgeries more, seeing more face to face, and footfall continues because it's 24/7. So I think any learning and sharing amongst other localities and around the patch would be greatly benefited, because I think people are struggling with footfall in some areas.
Yeah, no, I agree. And yeah, it's one of the reasons why it was developed, and we've developed that with EC, the traffic light system. And I'm more than happy to share anything. And we have shared it with some of the digital colleagues around what that is. And we have had help from Anne's team as well to develop it, to make sure it's kind of embedded properly. And I was very skeptical at the start, I'm not going to lie. When I saw a traffic light system, I've seen a few come in my time, but this one really is practical. You know, it's almost as simple as, actually, okay, they're an amber. It takes into consideration their conditions or their multiple morbidities, and then makes a recommendation of who they're seen by for that particular issue. I can't get into the technical algorithms and things like that, but it gives, there's plenty more people out there that can do that, but it really is as simple as that. It gives you like a traffic warning who they need to see that day. And I think you might want to come in on that.
Thank you, Ben. I was just going to say that we're actually working with Silicon Practice, the supplier of footfall, and System 1 to have the traffic light indicator in System 1 displayed in footfall during triage, which will assist with care navigation.
So yes, I think it's definitely the way forward, and our practices have really, kind of benefited from having day one, especially coming out of COVID. The PCN strategy group was a little bit of a response to COVID, if I'm honest. So I think it was some of the pressures we saw locally, where we wanted to try and make sure that actually we had a kind of system in place where we could have a decent, robust conversation about direction and way forward for all providers in the area. And that wasn't to cut across anything done centrally or anything like that. It was just more to make sure we were all aligned, and any issues, kind of arisen that we needed to make sure we dealt with, because hot hubs were a real kind of new concept for the area, and we needed to make sure that communication was done properly, and also how then, so if a COVID patient presented in a hot hub, how then would they access the acute, what is the route in, and things like that. So really kind of practical delivery, and then it kind of almost that group now is looking at how, you know, if we have a local lockdown, some protocols and SOPs for how we, you know, deal with that in the very near future if that happens.
Any other questions for either Ben or Kate? John?
I've got a question, and I think Kerry was trying to come in on the chat as well. So just a question for me, Ben. Interested with PCNs being a year in now, and PCNs different layers within the locality. What's the role of the GPPO now within that landscape, if you like, or what role is evolving for them?
Yeah, so it's a really, really good question, and one I may not be able to answer, because I think people are trying to find their place. There's some GPPOs that are a bit more advanced than others. So in our area, it's very low level. It's, you know, there is literally one individual in there, and they basically act as a bit of a broker with some of the conversations, you know, some of the place level messages we need to get across, and they are actually seconded from my team. So I still think there is a place for them. I think in terms of, you know, that place level conversation, I do think that really helps. I think PCNs have added a new complex to that relationship. And, you know, PCNs now for us are wanting to hold, you know, kind of LCS contracts as a whole and things like that, where you would have seen other GPPOs normally stand in that role. And that might be right for that locality, depending on where you are. But it's a tricky one to answer. But I would say since PCNs are evolving and maturing, there might be a question, you know, that question needs to be asked, I think, continuously going forward.
I think Kerry wants to come in with a question. Kerry?
Yeah, so it's not the one I put in the chat. That did kind of get answered within the presentation, so thank you. My question is how you can balance out the willingness to reduce inequalities with going very digital, because in the rest of Suffolk, we're doing stuff around with the CCG, where there is a big load of work going on, listening to BAME communities, and how the engagement with digital is very limiting. So on the one hand, you've got the will to want to reduce inequalities. However, that really doesn't go hand in hand with the push towards digital. So where's that balance, and how is that going to work going forward?
Yeah, I definitely hear what you're saying, Kerry. I think the digital piece is a complex piece. I think if you look at the national picture, there is a real drive to, you know, for digital solutions and innovation within surgeries, but also acute and community settings. I think there's always got to be an alternative to that, because there isn't, or, you know, not everyone has a smartphone or a computer or even Wi-Fi. I went to someone's house that didn't have a Wi-Fi yesterday, which was very strange. And, you know, that we knew, so for all of our practices, there is still that option to be able to pick up the phone and make that normal access as they would before. I think one of the things that we have seen through the digital piece is effective use of resources, and actually appropriate, you know, practices can then look at kind of that, what things are coming in. So rather than have to be quite reactive, they can be relatively proactive. And I think that's definitely a change. But you know, you've definitely hit the nail on the head, Kerry. I would say there is definitely a piece of work to do to make sure we've got that balance right.
So my follow-up on that is, what is being done with BAME communities that going forward, knowing what can work for them, because there are stuff that digitally can work for them, but rather than, this is what we've been learning at this other thing with What Are We Missing, it's called, some of you may have heard of, the rest of Suffolk. It's understanding the need and responding like that, rather than doing something and then an accusation going out, oh, they don't, won't engage with us, kind of thing. That's kind of been the criticism from BAME communities, that things are done to them, not with them. And there are stuff. I mean, we've seen browser lounge really good. So looking at that, is that something we looked at with linking with the contract with around the interpreting services and stuff like that? So I think saying it's okay with people to still ring it up, but you will still miss out on lots of stuff because we're having ethnic minorities saying they can't get through on the phone, as well. So it's really difficult. And
Do you want to comment?
I was just going to say that's interesting, Kerry. I don't think we've made any link specifically between BAME and digital inclusion. So I'd be very interested to hear more about that and think about how to take it forward and the work you've been doing. I just wanted to say that in terms of digital inclusion, we funded a project with the library service this year. Unfortunately, of course, with the COVID, the libraries had to close, but they still made good attempts to carry on that work over commonly used social media. Totally appreciating you still have to have some sort of device to use Facebook, but they use the more commonly accessed social media to promote the digital tools for accessing primary care. Prior to that, they were offering one-to-one sessions in the library. We also think about whenever we're rolling out apps or text messaging and things that again you need a lower level of digital, but using an app so that the user doesn't have any cost for a text message, that they can actually reply to the practice via their phone contract, if you like, rather than or a Wi-Fi, rather than paying for a message. So we do consider things like that, but certainly. With the Digital First Primary Care funding for 2021, get my years right, we will be talking to our colleagues at Health Watch about a bigger digital inclusion programme and what we can do. So anything you've got to input to that, I'd be really interested to hear.
We're actually doing an ICS-wide digital project at the moment for
something
Precinct 6. So I was going to share that later with the input with everything else, but I may as well mention it now since it's relevant.
I think Judith had a question as well. Chat. Judith,
yeah, that's fine. So in GYW we have a place level, so a whole PPG. So we have PPG representatives from all the practices where they actually meet and join together. And we're currently in conversations with Graham Dunhill about how we get some of that voice back into our PCN, because the virtual world is not made it difficult, but it's proven some challenges. But in GYW, I would say that we've got a reasonable, robust process in terms of that overarching group, but then at practice level as well. So we are in dialogue with some of our PPGs about how we make that PCN level voice rather than just practice.
Yes, I think my knowledge is such that one of the PPG forums in the county, and it's good to hear that you are in dialogue. I suppose I'm just waving that flag because we are in strange times and there's been many other priorities, so it's just a question of pausing and thinking, let's just make sure we don't forget the patients, the public, and we bring them with us and make sure they are included in all the decisions that are being made as much as possible going forward.
Very much so, and Graham has been a great advocate for the PPG, and I speak to him pretty much nearly every month just to keep him abreast of some of the things, and I know that's feeding back as well. So,
thank you.
Thank you very much, Ben and Kate. We did have some questions from Mel at the LMC via email, but I think they are being dealt with offline in response to Mel's question. There were some kind of more detailed questions around the paper, but that's been picked up, isn't it, Kate?
I haven't yet, but I can respond to Mel directly on those.
That's great. Thank you very much. No other questions for Kate and Ben? Thank you both for your very detailed presentations, and look forward to more updates to come. Thank you. Over to you, Anne, Digital Development.
Thank you. So I presented the paper, and I checked with Sarah, and she thought I was to attend for questions. That I should assume the paper's been read. Is that right, or is there anything you want me to go through?
No, I think you can assume that it's been read.
Okay.
And unless there's anything you want to particularly highlight, then I'm open to questions.
Okay, so I suppose in terms of things I would want to highlight was just the amazing response from practices during the pandemic in their adoption of digital tools. We could hardly move fast enough to keep up with them, but hopefully we did. We're only slightly behind them, so it has been really amazing, the amount of digital adoption that's gone on.
Are there any questions for Anne based on the paper? Tracy?
Sorry, and just a quickie, I know that certainly with the video consultations, the ability for patients to reply and send pictures to us and various things, I think across the system we're doing it in many different ways. We're using Footfall, we're using Accurex. I mean, there's capabilities with MJOG, and I guess it's, you know, is it left to us in primary care, or PCNs to decide, or is there going to be some kind of guidance or a route through, and just so we can kind of make sure there's some consistency and we're using kind of the best possible digital tools that we can, really, I guess is my question.
Yeah, great question, Tracy. Thank you for asking that. It's clear that there's no one tool fits all the scenarios for providing consultations, because they're an individual, or we're shortly rolling out group consultation training, and of course you've got the ward round scenario in care homes. The video consultations, as you know, was a target for next April 2021. So all of the tools were rapidly made available via a framework, meaning we can just use anything at the moment, but you're absolutely right that we will be setting the strategy, and by next April we will have to have procured a tool from the framework for use in general practice. Again, I think that's unlikely to be one tool. It might be that we have a variety of things, and it'll depend how they're funded. So Footfall, the one available via Footfall, I know that needs some improvements. Again, we're working with Silicon Practice on that, but it's available from the framework. MJOG is free within the contract for MJOG, so will be, and MS Teams obviously is also available, so we'll be what's available in the framework and talking to practices about how they're using the online consultations, the video consultations, and taking it forward from there.
Thank you.
Any other questions, John?
Just a comment really, Doris, just to recognise, as it shows in Anne's paper, that the enormous amount of work that's been done by the digital team with primary care these last few months. And I know from regular conversation with Anne, the amount of really positive feedback from practices, from patient groups, from all sorts of different sources in terms of the huge amount of work that's been done and continues to happen. And things like with all of MS Teams that's referenced in the paper, that's happening at the moment, and that will be another step forward in terms of practices and PCNs being able to work more effectively together. So just recognition of that work, really.
Thanks, John. Yes, it's amazing how we've gone forward years. We wouldn't have. I think it's quite a feat to be able to get all that kit out as well, because personally, trying to get a laptop during the height of the pandemic, if you weren't fast them up, got anything. So it's up to you.
Thank you.
No, thank you very much. Very helpful. It's always interesting to see with the 21st century.
Thank you.
On to the GP survey. We're back to Kate.
Hi there. Am I good to go, Chair?
Yep.
Okay. So the paper provides an overview of the results of the GP patient survey, and it compares Norfolk and Waveney CCG practice results to national average. And the survey assesses patients' experience of healthcare services and predominantly looks at access to GP services, ease of making appointments, and quality of care received. So this is an annual survey published by Ipsos Mori, and it's important to note that the data collated was pre-COVID. So the survey shows the results for the period January to March 2020. For Norfolk and Waveney, we had a response rate of 44%, which I think is about in line with the national average response rate. Really important to note that the survey has limitations. For example, small sample sizes, and it doesn't include qualitative data, so it's purely numerical results. And if we look across the CCG overall, we score above average. So I think this year was probably the best, one of the best that the CCG has done on the survey. But one area which related to choice of appointment, where we came out as equal to the national average. So I won't go through all the questions detailed within the survey. Within the appendices, you'll see the slide deck, and contained within the paper is a summary narrative on each of the questions. So I'll take that as read. But I do want to draw your attention to some of the differences between the practice ranges. So though overall the CCG response to the practice to the questions has come out above average, there is some quite big variations between practice responses. And so, for example, I could draw your attention to the question which asks, how easy is it to get through on the telephone? You'll see there's a variation between 28% and 100% of patients answering very easy. And that's a stark contrast. But again, we can't draw big conclusions from this. So it's important to note the small sample size within survey results. And then when you drill down to practice level, you can really then start to make comparisons. In terms of recommendations for next steps, I'm suggesting that the locality leads support their PCNs to review the survey in greater detail, and also then to look at the comparison between practices within their own PCNs. And it's really important that they take into account the local context. And just on that point that I draw your attention to, which was the variation between ease of access. Since COVID, we've implemented a total triage model. And so the access model across Norfolk and Waveney has changed. So again, important not to draw significant conclusions from this survey.
Thanks, Kate. I think it's good that the locality team will pick up some of those variations, and although surveys have limitations, they do kind of highlight, and it could be it was done on a particular day and all the rest of it. But I think there are uses that we can learn from and improve. Are there any other questions for anybody from the GP's patient survey? No. Thank you very much, Kate. Move on to the general practice workforce and training. I think Andy Lamb's with us. Over to you.
Yes. Hi. Good afternoon. Thank you, everybody. Just to give myself a little introduction, I'm Andrew Lamb, the senior GP Forward View Workforce and Training Manager for Norfolk and Waveney CCG. I know a few of you on the call, some I haven't met before, so it's nice to meet you. I started in post around the 5th of March, just sort of before COVID all hit. So it's been a steep learning curve for me, put it that way, but it's nice to meet everyone and you, Chair. So yeah, due to the coronavirus, a lot of the training within Norfolk and Waveney was put on hold, as a lot of the team were redeployed, and obviously there were major areas that were of more concern, patient care, than having education and training going on. So we've looked through areas within the training and development section that were put on hold for COVID, these being the general practice assistant pilot, the GP fellowship, physicians associates, apprenticeships, and recruitment for clinical pharmacists and pharmacy technicians. These programs are now back as we're starting to get back to more of a business as usual role within COVID times now. I'll take it that the paper has been read by everybody, so I'm not going to go through each program that has been put back on and we're running out there. But what I would like to focus on is the training needs assessment that was done pre-COVID, that we were putting plans into place for the TNA, the training needs assessment there. This obviously, in the light of COVID, certain areas are changing at the moment, and we are in talks with PCNs around areas that they would like to see changed. And one of those, or some of those key ones coming up, are around digital consultation, training for mental health training, awareness for staff and for patients, because COVID's had an effect on people, better understanding of long-term conditions and how COVID has affected those long-term conditions. So we are going to be relooking at our training needs assessment to see what we need to alter in light of COVID and how we can best support the GP practices out there as well. Primary care network workforce planning submissions have to be in place by the 31st of August from all of our PCNs. And in discussions with the PCN development managers there, they're all happy with the submission dates and the requirements, and they're all going to be able to make sure that those submissions are in time. And we are currently working with the PCNs to help with the difficult recruitment that others have mentioned around the additional roles within the GP practices. As has been mentioned earlier, clinical pharmacists are quite difficult to source. We're also working with the East of England Ambulance Service for a rotation programme to have paramedics within primary care, and that's going really, really well. And we are in talks with our colleagues on areas and trying to learn from other areas of how they've been dealing with the additional roles reimbursement scheme and the recruitment issues nationwide. International GP recruitment, that is going, or has been continuing throughout COVID. It hasn't stopped throughout COVID because it's been a very much an online program. So we're continuing ahead with that. Although last week we were notified that as of the 30th of November, that the international GP contract scheme ceases. We can still recruit up to the 30th of November, and the support will be given to the international GPs who have been recruited so far past the 30th of November. But the international GP recruitment is going really, really well, and we're sourcing places for people within the Norfolk and Waveney area. We're changing the governance and oversight of the training hub. We're now going to be starting a new group, which is a very, very catchy title, the Norfolk and Waveney Primary and Community Care Training and Workforce Steering Group. We're going to come up with a shorter name of that to try and get it a bit more catchy so it doesn't take up everybody's diary allocation in one hit. But that's a sort of a combination of other boards that we've had, the Primary Workforce Systems Assurance Group. We tag in with HEE and NHSE, and that's going to be as most things are now, an online bi-monthly meeting and having a sort of a multidisciplinary representation from all aspects of primary care. Next steps that we're waiting for, and I can't provide you with papers on today, but they will be hopefully ready for the next primary care board meeting that we have, are on the allocation of money from NHSE. They're a bit behind due to COVID, so we haven't had the allocation of where our monies are at the moment, but like I say, I'll hopefully provide them at the next PCCC. There are a few risks that we're concerned with within the training and workforce area, and that again has already been highlighted, so I'm not going to dwell on these much, but it's a lack of qualified candidates for the additional roles reimbursement scheme, and we're working particularly with UEA, School of Pharmacy, and other pharmacy schools to try and capture more clinical pharmacists to work within the North and Waveney area. And we're also, like I said, working with the East of England Ambulance Service to try and work on the rotational paramedic role within primary care. So we need to start looking at future ways of organising our workforce. So we need to look at talent pools and building up a base of staff that are interested to work in primary care within North and Waveney, keeping them informed, keeping them updated, making sure that we're there when they are looking for the correct roles, and we can update them and support them necessarily, because about 31% of our current primary care workforce are in the 55 and over bracket. So we're getting towards that retirement end and getting to see our workforce starting to decline. So we need to start looking towards the future and having those talent pools in there. We also need to look at hiring faster, because some candidates are in high demand, clinical pharmacists in particular, and if we're taking too long to hire, they're going to go elsewhere. So we need to improve our hiring times and make sure that we're getting there quicker and getting people into our practices that we need. We need to start working far more collaboratively, that's difficult for me to say, collaboratively with other PCNs, to make sure that we're linking in with them and maybe picking up workforce areas or training areas that we can utilise with them and support each other to try and get a cross match of working. Again, the pandemic, that could be a possible risk to our workforce and to training. Again, if we have the second wave, we need to plan in for the recurrence and where we're going to put our clinical mix of staff and how we're going to cope with that clinical mix. We are looking at developing a volunteers pandemic or emergency talent pool. Everybody who's helped us so far, we're keeping hold of their details and saying, in the event of another pandemic or another emergency at short notice, can we use you again? So that's something that we're looking on to try and reduce the risk if we have another pandemic. We're also looking at working with external agencies, recruitment agencies, to support PCNs in the recruitment of additional roles reimbursement scheme as well. So there's quite a few areas of focus. It's a bit of a whistle-stop tour there. If anybody has any questions, I'm happy to answer, hopefully be able to answer, but just bear in mind, I am relatively new. Thank you, Chair.
Thank you, Andrew. Yeah, Mark.
Thank you, Andrew. Really helpful to hear that, and grateful for the report. Could I just ask? One of the things I think we've suffered from in North and Waveney for a long time is it's good to hear about the ambulance staff rotational programme in primary care, but we often hear about in North and Waveney how we rob Peter to pay Paul with our resources. So very often, despite advertising a great number of resources, more often than we're not actually increasing the overall workforce. It's just we're moving our existing people around. Can I just ask what kind of additional work there is taking place to try and encourage? I know we're doing the homegrown piece with UEA, but actually, Norfolk and Waveney is actually a fantastic area to live, isn't it? And I don't think we, as looking as we move ahead to an ICS, how do we do better at encouraging people to come to this wonderful place that we're all fortunate enough to live in? In my simple mind, I think every single advert that we put out, doesn't matter which organisation we work for, wouldn't it be great if it had "This is Norfolk, isn't it wonderful?" The brochure that with it. So I know that I'm oversimplifying things, but grateful for your thoughts about the work we've done to try and improve that position.
Yeah, no, I totally agree, and it's a very good question. And it's not oversimplifying things. We do need to sell the virtues of working within Norfolk and Waveney, and what a wonderful place we are. So yeah, it is something that we're looking at, and something I've created previously of a brochure of selling the attributes, selling the schooling, the lifestyle, the education, all sorts of the benefits of Norfolk and Waveney, and then sending that out wider than we currently do advertise at the moment. We tend to stay quite close to home, so we need to extend our recruitment pathways and sell the virtues of Norfolk and Waveney. And like you say, we're not, sometimes, yes, we have been robbing Peter to pay Paul, but with the new paramedic rotation scheme, that's one thing that we're very careful of, because East have had a massive recruitment campaign there, bolstering their numbers quite well. We don't want to destroy their numbers, so it's, as I say, the rotational, we haven't worked out the finer details, but a 6-month primary care, 6 months back in East, and carry that rotational basis on, so we're not depleting their stock.
Fiona?
Hi, thank you. I just wondered, obviously with the COVID response, we had a lot of health workers return to work, which is great. But also, so I guess my question is really, is there a piece of work being done to understand how many of those might stay or be persuaded to stay for a bit longer? And secondly, are we aware, because during COVID, it's likely there'll be a lot of healthcare workers who perhaps, because of the stress of it, the challenges of it, actually are saying, I'm gone. Is there a piece of work to understand what the risks are and how many there might be in that category? Is there anything planned?
Yeah, with regards to your first question, I believe the STP have got a data sheet of who came back and who's working, and as someone as Anna Morgan is detailing those programs. So that's more in the STP's hand than my hand. So I haven't got those figures, I'm afraid, but it is a program that's being worked on, yes.
I think Tracy?
Yeah, I mean, I would sort of echo some of the things that would have been mentioned, but another point for me is new people coming in, so not just outside the area, but young people. So, you know, our colleges, our schools, we have a university, so how are we getting and then supporting and you know, enabling young people that live and have come to Norfolk to study, to stay and work here and join our health and care team. So that's just something for me that I don't think we probably do enough of. And the other aspect that you talked about, the rotation of the paramedics, fantastic, but rotation in other roles. So for instance, my background is paediatric nursing, and when I was a paediatric nurse worker in the hospital, I'd love the opportunity to rotate into the community. So there's other roles I think we potentially could explore rotation where there might be gaps as well.
Yeah, I totally agree, and it's something that's come to light through COVID, of how people have moved around a lot and they haven't been working in their predominant role. They've gone back to another role or gone in somewhere other area, and a lot of feedback has come back saying, I really enjoyed that chance to experience something new. So it's something we are looking at, of how we can rotate other disciplines around a lot more. Yeah.
Kathy?
Yeah, I think it's on the same theme really. So my experience is we're quite often good at a system, you know, having an STP approach to kind of rotating people. But quite often then in practice, say the nurse on the ward who's feeling a bit burnt out, you know, the only option is to leave. You know, the paramedic with the blank back, oh, I think I'll go off on sick leave, you know, this kind of thing. So I was just thinking in my head about the previous presentation we had about the relationships between, you know, primary care networks and local providers. And, you know, almost the STP approach or strategy needs to also translate to those local conversations. There's quite often middle managers who have a fairly kind of strict approach to things, where we could actually, if we were more flexible, retain more staff or have more staff working in more flexible ways. So that was my feeling about that debate. But I also had one question, which is I didn't pick up what barefoot coaching was when you talked about your training needs analysis, Andrew. Sorry if I missed that.
Yeah, no, I didn't explain that point, but the barefoot coaching is simplest way, coping mechanisms, coping strategies for people about how to deal with the work-life pressures, areas that they can go to. So it's to do with this sort of pastoral well-being support that we can offer staff.
I think there's just a question from me. It's more, you know, we're focusing on people already in Norfolk and Waveney in terms of workforce, but I certainly know of you know, young people who have gone out of the area to go to university or college. They get to a certain point in life, and the attraction of having grandparents close by is really high. So actually, how do we tap into that pool of people wanting to return? You know, they've spent 4 or 5 years or 6 years or 10 years working and training somewhere else, but actually they really want to come back. And how do we make it easy for them to come back?
That would again come down to Mark's point earlier of putting our net wider and selling the virtues of Norfolk and Waveney, and people who have grown up here and have the grandparents here would then maybe think, oh yeah, that's a possibility. I don't know if there are any other networks that we could tap into, but it's certainly something that, yeah, we need to be investigating. We need to be looking at a lot more, as Tracy has mentioned, about going in on careers days at schools and educating schools a lot more, and then passing that further down the line. So there's lots of areas that we need to look into, absolutely.
Doris, it's Sadie. May I just add something to Andrew's very comprehensive overview, and it's about your last point. I think one of the things that we're really trying to do now is bring Andrew's team to work much more closely with Anna Morgan's team, because Anna, there are a lot of things like the things that you've just mentioned around making life easier for people to come back, supporting people, that we can do as a whole system, and not just health either. This is, you know, this links into the councils and other public sector organisations, where actually we're going to be much stronger if we try and do these things consistently and together, because we can support each other. And we've seen things like this from the work that we've done on the international GP recruitment scheme, whereby actually we've put this big pastoral care package around individuals, where we've supported them with all aspects of their life, not just the working bit. We've helped them with schools, we've helped them with housing, we've shown them, you know, how to register with a GP practice for their family, you know, what to do at weekends, football matches, you know, with kids football, whatever it is. We've looked at them as a whole and how we can support them to come and work with us. And I think, you know, that's a huge amount of work. It's very intense around an international GP recruit. And if we're going to do it at a bigger scale, the only way that that's going to be manageable is by coming together as a system to look at it. But I absolutely agree with you. We need to help people to come and work here, and come and live here, because, you know, we've got fantastic quality of life in Norfolk and Waveney. So it's got so many good things going for it, and I think that we haven't always managed to market that as well as we perhaps could. So it's definitely on Andrew's list. It's a very, very long list, and he'll be coming quite regularly to update us on the progress of all of that, and capturing any further sort of suggestions and challenge as we go forward.
Thanks, Sadie. Just before I move back to Kathy, there was a question from Judith about, has the pandemic resulted in any greater than normal loss of primary care staff?
Not that I'm aware of, with figures wise, but there is a an inkling that certain GPs, as we said earlier, reaching retirement age, are thinking about retiring a little bit earlier. But I don't have any facts or figures on that. But I can find out for the next PCCC.
It might be a wee bit for that to come through. Kathy?
Yeah, I was just thinking about the comment about the quality of life here. In my experience, clinical staff particularly want to work somewhere that's good, that provides good quality care. And we previously, I mean, we were a bit of a basket case, and people didn't particularly want to come and work here. And I think, you know, that tide has turned. And I don't think we celebrate that enough. So, you know, the reason people go off to London and Cambridge is because they think everything's great there in terms of quality of care, and that's not always necessarily true. And I think we're a bit too polite here about the fact that we're doing some things really well.
John?
Just a quick comment in support of Andrew's long list of things that he's trying to do, and actually backing up Sadie's comment about taking a wider system approach to this. It might be worth, Andrew, taking a look into West Norfolk around some of this. They ran a very big campaign called Love West Norfolk. It included lots of social media, lots of external sort of promotional and marketing materials that were used. And I think I would absolutely back Sadie's comment. I don't think we got sufficiently far behind that in terms of health organisations around West Norfolk, and it's something that I think we should do. So they've done a lot of work, Andrew, which is why I'd point you in their direction. They might be able to support, and that was the Borough Council there in particular. Happy offline to give you a few details of people that were working on it.
Lovely. Thank you very much, John. That's very helpful, and I will do. Yeah, thanks.
That's great. Thank you very much, Andrew. Lots more to do. You won't be bored. Thank you. The last item was questions from the public. I've not been notified of any. So that's the end of this part of the meeting. I thank you all for joining in on a hot afternoon.